I'm going to deal with antiarrhythmics. So, antiarrhythmics are the drugs that act against arrhythmia. So, what is arrhythmia? Arrhythmia is defined as the generation of rhythmic action potentials in the absence of external stimuli. Generally, the SA node or AV node generates action potentials when they obtain the action potential from the external media. If the SA node or AV node do not acquire the action potential, and though they produce a abnormal action potential, so that condition is called arrhythmia. Arrhythmia, A means defect in rhythms of the heart. So what are the common terms that we look in this session is atrial flutter. Atrial flutter is generally the atria fibers beat at around 200 beats per minute, and they do not exceed 200. So in atrial flutter, the atrial fibers beat from 200 to 350 beats per minute. So it is a abnormal condition. In atrial fibrillation, the atrial fibers exceed 350 to 500 beats per minute. In ventricular arrhythmia, it is defined as the arrhythms in the ventricle regions. Ventricular tachyarrhythmia, it is defined as abnormal heartbeats due to arrhythms. So what are the general causes of arrhythmias? There are two common reasons causing arrhythmia. The first thing is difference in impulse generation. We can also call it as abnormal automaticity. Second thing is defect in impulse conduction. That is change in impulse conduction in the heart. So what are the main theory considered in case of difference in impulse generation? We'll look into the normal impulse conduction. First, the SA node in the heart acquires the action potential from the external stimuli, and this SA node action potentials travel through AV node and then to his bundle and Purkinje fibers. So here the SA node transfers the action potentials very fast. So here we can see fast depolarization. Due to this fast depolarization, there is a contraction of the heart. So we can say it as the SA node wants to be the king of the kingdom, and it cannot tolerate any other organ allowing the contraction of the heart. So SA node is the only thing that is responsible for the contraction of the heart. So what in case of difference in impulse generation means? If contraction was due to other than SA node, sinoatrial node, if the contraction of the heart occurs not due to the synovial node, then it leads to generation of competing stimuli, that is stimuli other than the SA node generation. So we can see a competing stimuli, and this leads to arrhythmia. So two stimulus are produced, so that leads to arrhythmia. In case of defect in impulse conduction, in general case, this is our ventricle. Here impulse is entering into the ventricle, and then it is bifurcated into two sides. And these impulses can move here and here. This is the general theory in case of ventricles. If there is change in impulse conduction, when we'll see a change in impulse conduction means when there is any myocardial injury or prolongation in refractory period, there we can see a change in impulse conduction. Just in case of unidirectional blocks, that is block in one direction. So here we see a block in this direction, so the impulse moves from here and to this side. From this side the impulse moves back to the origin, and it again enters the one direction, and it also enters into this direction. So here re-entry takes place, that is impulse is moving from this side and then it again re-entering into the original action potential. So it is not giving chance to the upcoming action potential to generate the contraction. As it is re-entering into the original action potential, there is a abnormal contraction of the heart takes place. This phenomena is called re-entry. it leads to generation of abnormal conduction, that is the heartbeat is increasing. So as this is re-entering whenever it re-enters into the original action potential, it causes a contraction of heart. So other than the original impulse, this re-entered impulse also creating contraction of heart. That so in this case it is leading to increase in heartbeat. So this is called anti-arrhythmia, arrhythmia. Till now we have come to see what are the causes of arrhythmia, and now we are going to see what are the drug targets in case of arrhythmia. First thing is we have to block sodium or calcium channels. Why we have to block sodium or calcium channels is to decrease abnormal automaticity. We have seen this decrease in abnormal automaticity in case of defect in impulse generation. So this abnormal automaticity is due to the ectopic pacemaker cells. Ectopic means other than the original organ. So automaticity, generation of action potential other than the SA node, is called ectopic pacemaker cells. So we have to block sodium or calcium channels to decrease this abnormal automaticity and preventing re-entry of sodium channel, preventing re-entry of potential action potential. This re-entry can be prevented by sodium channel blockers. And the third thing is increasing refractory period. Here if we increase the refractory period, then the action potentials take time to re-enter into this process, and at the same time the impulse also comes, and they both combine, and thus extra contraction is prevented. So we have to increase the refractory period. This can be done by blocking potassium channels. Refractory period in case of unidirectional block, refractory period can be increasing refractory period leads unidirectional block to bidirectional block, that is these two directions can be blocked. So what are the drugs that are used in case of anti-arrhythmia? Classes of drugs used in case of class 1: sodium channel blockers. Sodium channel blockers are the drugs used to block the sodium channel in case of phase O. What are these phase 0, 1, 2, 3, 4? We'll see in the later sessions. Examples for sodium channel blockers are disopyramide, procainamide, flecainamide, lidocaine, mexiletine, quinidine, propafenone. In class 1, drugs are classified into 1A, 1B and 1C. 1A, 1B and 1C, they are classified based on the action, based on the area of location of the action they show. We'll see in the later sessions. Class 2 drugs are beta adrenoceptor blockers. Examples: beta blockers, whatever the beta blockers you can add them. Examples: atenolol, esmolol, metoprolol, sotalol, etc. Pintolol. In class 3 drugs are potassium channel blockers. Examples includes amiodarone, dronedione, dofetilide, ibutilide and sotalol. These are the examples for potassium channel blockers. And in class 4 drugs are calcium channel blockers. These calcium channel blockers examples are diltiazem and verapamil. These are the non-dihydropyrimidine examples of calcium channel blockers: diltiazem and verapamil, and others, that is miscellaneous. Examples: digoxin, magnesium sulfate and adenosine. These are the classification of the drugs that are used in case of arrhythmia.